One of the things I keep coming back to in IBD is this disconnect between gut inflammation and symptoms. It really seems so self-evident to us now in 2025, but in two decades ago, that wasn't really the case. We were managing patients when they arrived with symptomatic flares. We would treat it with a course of prednisolone. We didn't really have good tools to monitor, nor in fact good drugs to get people well. And so patients would disappear and then they would come back in with major intra-abdominal catastrophes if they had Crohn's disease or really acute flaring colitis. But over the time, we have learned to observe and really respect this disconnect. It's why, with our patients, we explain as best we can that we need to monitor both symptoms and inflammation and, of course, quality of life. They're all important, but inflammation is the danger signal. Inflammation is the thing that we can properly manage with our toolkit of anti-inflammation medicines that really work and our monitoring strategies for inflammation, whatever they are. And so learning to respect that and to understand it has become the centerpiece of IBD management through Stride 2, currently treat to target paradigm. But what does this inflammation over time really mean? How can we better understand it? We've looked at trajectories of patient behavior over time in terms of rather stochastic measurements, going from inflammatory to stricturing to penetrating disease, looking for that Montreal progression, looking for surgical events, looking for treatment escalation events, for hospitalizations or courses of steroids. None of it really works well enough. So that's why we're thinking very hard at the moment about how we can model longitudinal inflammation patterns. What happens to inflammatory markers over time? And so in Edinburgh, where we have been using calprotectin, faecal calprotectin, on the same cheap $10 to $15 per go assay in the lab for 15 years now as routine clinical care. So we have tens and tens and tens of thousands of measurements, most patients who accumulate a median of 10 plus measurements over a relatively short period of time, plus the bloods, especially the CRP. So I now have a team of 3-4 very, very smart postdoc data scientists, mathematicians, Nathan, Victor, Alex, working in very close collaboration with Catalina in the same unit, where we are redefining how you describe IBD behavior over time by using sophisticated and indeed new mathematical models to look at those longitudinal calprotectin and CRP trends, to model them as multivariable and soon multimodal models, so that we can do two things. One is look at our population and cluster patients by their inflammatory behavior, so we can pick out those people doing very well and maybe shift them to a patient-initiated follow-up mode of care. But importantly, to identify those that are doing very badly and pull out within that the group that we don't know about, so that we can intervene early and then take this and move it into a RAG-based system, service-level RAG system, so that we can have that group that we need to proactively contact. And then to do the harder thing, which actually is to take the individual patient, look at their trajectories, not only just track for tracking's sake, but predict what will happen next. To do this requires dynamic prediction that incorporates both landmarking methods and latent class mixed modeling. It's a complicated task, particularly when there are multiple variables. IBD is not easy to model, but it is possible. And we are getting now very close to an analytics engine that will drive both parts of this. The service level view that will help us identify those groups of patients, and then that individual patient tracking system. And so we're building a tool that will allow us to do this. We call it Sentinel, Smart Early Notification and Treatment Intelligence Network for Lothian. Lothian being the county where Edinburgh is with 1 million people. But we are building locally to fix our pain points for our service and for our patients. But most of these are universal. This is an EHR adjacent system that simply requires a live feed from the labs to get the bloods and the calprotectin to do the dynamic monitoring. Yes, when we add our Lothian IBD registry phenotyping and rich history data, that will transform what it can do. Yes, when patients engage with patient-reported outcomes, quality of life, anxiety, depression, when we add the wearables data, which is already set up and integrated, when we add omics, it will do so much more. But this system, this tool, Sentinel, an AI-driven, dynamic, clinical decision support tool with a patient companion app, we believe will totally transform IBD care. We'll be building it locally so that we have a test bed for the models to be trained and validated and improved. This is a closed-loop, continuously learning system. The models will get better, but for an individual patient, as each data point comes in, the system learns for the patient what is happening. So look out for this. We are getting ready to launch a pilot already with the first patient in January. We have a fully functioning system. We have the core of the analytics engine ready. This is not easy. We've been working on this for a long time, but expect to hear a lot more about this because we will build it locally, but we will be ready very quickly to scale wherever you are, to meet local needs, national needs, to be able to collect research and to be able to plug and play and test those innovative biomarkers that I hope will come soon. But you can put a patient on in January who already has 5 years of CRP and calpro data and already the model is working. The stickiness that's such a problem with current tracking systems will not be an issue here because patients will want to engage because they'll see the benefits from day one. But even if they don't, it will still work. This is an equitable tool to drive forwards and transform IBD progress. We're building it, but I want to share more with you as we go. We are going to build this in public so that we can build it together. Keep tuned.